Principles of optimal antimicrobial prescription. The appropriate use of antimicrobial is the core of antimicrobial stewardship. If we follow these principles, it improves patient outcomes, reduces the antimicrobial resistance, and minimizes adverse effects. Let's look at what they are. Four key principles are recognized as the 4 Ds of optimal antibiotic use. The first D refers to the drug. It means that right antibiotics is selected to be most effective for the specific type of infection. Selection of antibiotics are based on which bacteria cause which infections and knowledge of local resistance patterns. For example, you suspect the patient with enteric fever. The likely pathogen is Salmonella typhi. Therefore, its first-line treatment option should be fluoroquinolone. However, fluoroquinolone resistance is very common in this region, and it is highly likely for this patient having fluoroquinolone resistant Salmonella infection. That's why ceftriaxone is the appropriate choice instead of fluoroquinolone for this particular case. We also have to consider the ability of antibiotics in the tissue penetration. Nitrofurantoin, for instance, is a recommended drug for treating urinary tract infections, but its penetration to the kidney is very poor and makes it less suitable for treating upper urinary tract infections. However, it remains a drug of choice for lower urinary tract infections like cystitis. Another factor to consider is which type of patients are likely to get specific infections. For example, the patients in intensive care units are at a higher risk of acquiring healthcare associated infections. Ventilator associated pneumonia, commonly seen in ICU settings, often involves pathogens like Pseudomonas aeruginosa, which are uncommon in community acquired pneumonia cases. Consequently, the antibiotic selection should prioritize coverage for Pseudomonas aeruginosa in such particular scenario. Additionally, the recent antibiotic history should also be considered. If a patient has received ceftriaxone during his last hospital admission, it is suggestive to explore the alternative options rather than opting for ceftriaxone again. By this way, it can mitigate the risk of developing bacterial resistance to ceftriaxone and promote effective treatment by utilizing the different antibiotic classes with distinct mechanisms of action. The second D to consider is dosage. The antibiotics should be administered at an optimal dosage, avoiding both underdosing and overdosing to ensure effective treatment without unnecessary risks or complications. As an example, if amoxicillin 500 mg is prescribed for the community acquired pneumonia, it is underdosed. This can lead to therapeutic failure, inability to clean the infection, and the development of resistance to amoxicillin in the future. Conversely, if gentamicin is prescribed at 10 mg per kilogram for neonatal sepsis instead of the recommended 5 mg per kg, it can lead to renal toxicity in the baby. Therefore, it is important to provide effective treatment with optimal doses while avoiding the adverse effects. The third D refers to the duration. The duration of antibiotic prescriptions varies depending on factors such as the site of infections, the type of pathogens, and the patient's clinical response. Let me give an example of meningitis. If an antibiotic is prescribed only for 3 days, which is apparently too short, and it could worsen the condition of the patient and potentially life threatening. If antibiotic treatment is not administered for a sufficient duration, the infection may not be fully cleared, leading to persistence or recurrent meningitis. Additionally, the premature discontinuation of antibiotic therapy can contribute to the development of antibiotic resistance, making future infections more difficult to treat. As a second example for duration, the optimal duration of amoxicillin for a mild case of community acquired pneumonia is 5 days only, but it was prescribed for 10 days, which is too long apparently. Prolonging treatment beyond what is necessary doesn't mean necessarily improve patient outcomes. Instead, it increases the antibiotic exposure, raising the risk of side effects and antibiotic resistance. Furthermore, it disrupts the body's normal flora, potentially causing antibiotic associated diarrhea. Therefore, it is important to adhere the recommended duration of antibiotic treatment, which is neither too short nor long, to ensure the best possible outcome for the patient. The last D is the de escalation. This involves reassessing the antibiotic therapy based on culture and sensitivity results, as well as the patient's clinical response. For example, in the case of neonatal meningitis, which can be caused by either gram positive or gram negative bacteria, the empirical therapy should cover for both types. That is why it is initially treated with ampicillin and gentamicin. However, after receiving the culture and antibiotic susceptibility testing results, the treatment should be adjusted based on the identified pathogen and its sensitivity profile. For example, if Listeria monocytogenes is identified and shown to be sensitive to ampicillin, gentamicin can be discontinued and treatment can continue with ampicillin alone. Another type of de escalation is switching IV to oral treatment. Stepping down from IV to oral is recommended for the most clinical situations. This approach helps avoid complications associated with IV catheters and facilitates the continuation of treatment on an outpatient setting. For example, if IV ceftriaxone is prescribed for severe pneumonia and the patient shows improvement after 72 hours, IV ceftriaxone can be stopped and replaced with oral amoxicillin to complete the total treatment duration. In conclusion, applying the 4Ds can improve antimicrobial prescription practices. Therefore, it should be promoted and educated among prescribers. Thank you.